susceptibility signals, right? And what you're seeing here on this glioblastoma is the presence of dots and bars, right? And those dots and bars represent either hemorrhage and or areas of hypervascularity, right? And of course, we do not count them, right? But people have counted them for the purpose of research. And they have found that in general, when a tumor tends to be higher grade, that you tend to have more or a higher number of susceptibility signals in the tumor, right? From WHO grade 1, 2, 3, and 4, you can see how the number of intralesional susceptibility signals increase in the tumor because higher grade central nervous system tumors tend to hemorrhage more frequently. And this is one example of that that was a glioblastoma, the prior one, right? And this one is a pilocytic astrocytoma. The pilocytic astrocytoma, you can see here the classic appearance of an enhancing mural nodule with a cystic portion. On the SWI, you see that there's no hemorrhage within it. But because everything in imaging, in neuroradiology, in medicine, there's always an exception, right? And you can see here another pilocytic astrocytoma that does have some areas of hemorrhage, right? So we do see some hemorrhage in some pilocytic astrocytomas because they are, the vessels are not normal. The vessels are a little bit ectatic. They are more friable. So we do see some hemorrhage, but it is not as common as in patients with glioblastoma, for example. Right? The patients with higher grade tumors, they tend to hemorrhage more frequently. So this is one utility of SWI, right? Another utility of SWI is this, right? Here you have an abscess, and here you have a glioblastoma, right? Both of them presented with a ring-enhancing lesion on the postcontrast T1. Now, if you have a patient where you suspect an abscess, diagnosis of an abscess on MRI is easy, right? You see a ring-enhancing lesion with central restricted diffusion, it's an abscess. But every once in a while, you're going to get a patient that comes in out of the blue, and the patient may not have fever. The patient may not have leukocytosis, and half of them do not have fever or leukocytosis, and they have a ring-enhancing lesion, and it's hard to know if it's an abscess. And some metastases may have restricted diffusion, right? Some glioblastomas may have restricted diffusion centrally because of hemorrhage. So sometimes it's difficult to make that distinction. We've had patients in the past who have cancer somewhere in the body, and then they come in with a ring-enhancing lesion. In at least two of them, it was an abscess, right? And it was not suspected, right? But what saved us and made us think that this was an abscess and not a metastasis or a tumor like a glioblastoma was the presence of a double rim sign on SWI, right? And if you see this on a ring enhancing lesion, you have a central concentric bright ring, which it is thought to represent collagen, and a peripheral ring of phagocytizing macrophages, then that's essentially pathognomonic of an abscess, right? So it is not always present, but if you see it, it is very helpful. Now, compare that to a glioblastoma. A glioblastoma does not have a well-defined capsule, right? A glioblastoma, we talked about it later, those intralesional susceptibility signals, those present like dots and bars, right? That's what you're going to see in glioblastoma, but you're not going to see a well-defined double rim like in an abscess, right? And also the metastases are not going to have a well-defined double rim. So this is very helpful if you see it for those cases where the patient might present with an abscess. So remember when we were talking about that algorithm for how to characterize tumors molecularly and pathologically, we briefly talked about the H3K27 altered tumors. So those are part of tumors that have histone mutations. This is now called diffuse midline gliomas. It includes what we used to call diffuse intrinsic pontine gliomas. These are tumors that come from mutations in different histone genes, right? That 27 number is just the position, the amino acid position of the lysine residue within that histone, right? But you're going to be hearing about this more and more. H3K27 altered, those are your diffuse midline gliomas. They are seen in children and young adults. They are poor prognosis by definition, as we saw earlier. These are WHO grade 4 tumors. This is a classic case of what we used to call a diffuse intrinsic pontine glioma, right? And most of these are going to be H3K27 altered. And classic presentation like this, right? Midline pons is a good place. They look infiltrative, mass-like, expansile. Sometimes they might wrap around the basilar artery to some extent, right? They may or may not have enhancement. They can occur at other places. Here you can see in the thalamus, centrally, that's a normal signal, bithalamic glioma, what we used to call, those are diffuse midline gliomas mostly. Right, so these are highly aggressive tumors. Now, moving to our next group of tumors, these are glioneuronal and neuronal tumors. This is a very nice example of a DNET, right? Disembryoplastic neuroepithelial tumor. Now, these are tumors that are relatively indolent, low grade, but they may be associated with seizures. And they most commonly occur in the temporal lobes. And they characteristically have this appearance, as you can see here, that you have a lot of rounded, almost cystic looking areas, right? Almost like soap bubbles, right? But they are not truly cystic, right? They're bright on T2, but they do not suppress on flare, right? So they are not perivascular spaces. They are not simple cysts. This is tumor, right? It just looks very bright and rounded, right? But that soap bubble appearance is very characteristic. Here is another one where you can see this tumor here. They tend to be peripheral, cortically based. And here you can see that the tumor has led to some scalloping of the inner table of the calvarium, right? You can see this here because the tumor has been growing very slowly. So these are tumors that grow slowly. And you can see a lot of like cystic looking areas at the periphery, right? A little bit of a soap bubble appearance, right? That's very characteristic. Now, most of these DNETs do not enhance, but about 1/3 of them may show enhancement, and that enhancement can be in the presence of a nodule of enhancement, or you can have a rounded region of enhancement, a rim enhancing lesion of enhancement, like in this case. And they may be associated with areas of cortical dysplasia that you may or may not see on imaging, but those are associated as well. The other fairly characteristic appearance is somewhat of a triangular shape, but also, again, a cortically located tumor. Now, see how bright they might look on the T2 sequence, and that is important for this other case. Now, this is a case of a patient, 16 years old female, who was being followed over serial scans because she was thought to have a slowly growing cyst. And you can see here on the axial T2, and left lateral ventricle almost looks like a cyst, right? You can see a little bit of like a membrane here, right? Very bright on the T2. You can see it here on the T1. It's a little bit brighter than CSF. But when you do the flare, it doesn't suppress, right? So it's not a simple cyst. On the flare, it looks heterogeneous, right? And the other feature here is that you can see a rim of hyperintensity, right? A bright rim around it, right? So that's important here. There's no enhancement, right? That's also another feature. And this is something called a myxoid glioneuronal tumor, an important entity that was introduced as a new entity in the last WHO classification. And it is important because it is frequently confused with a cyst, but it is not a cyst. It is a tumor. It is a slow-growing tumor, but it is a glioneuronal tumor. And we have seen already several cases of these, and all of them come in with referring provider or even radiologists, thinking that it is a cyst when it is actually a slow-growing neoplasm. And something that we have done sometimes is do a KISS sequence. We talked about the KISS sequence or CIS sequence, or Fiesta C can do the same thing with contrast. And you can see when you do that, small field of view, high resolution, small size thickness, 0.6 millimeter, then you can see that the tumor has kind of a spongy texture, right? So it is very myxoid, therefore the name, right? But because it is very myxoid, it will look very, very bright on T2. It will look almost like a cyst, but it is not a cyst. So this is somewhat related to the DNET because on histology, it looks very much like a DNET. So it used to be thought that this was the same tumor, and they used to call it septal DNET, right? Because they look very, very similar on pathology, but they have a different genetic mutation in the PDGFRA gene. So they are distinct entities, right? So they are different tumors. This is a WHO grade 1. They tend to occur in the septum pellucidum, where I showed you frontal horn of the lateral ventricle, typical localization, but they can occur in other locations of the central nervous system as well. Another tumor that you will encounter in the low-grade category of glioneuronal tumors is this one here that is called a multinodular and vacuolating neuronal tumor, or MVNT. These are classified as WHO grade 1 tumors. They are indolent. Some people think that they might even be some form of malformative entity, but they are still classified as tumors by the WHO. And they usually do not do anything. There's some reports of a couple of them occurring in patients who had seizures, but it is not known if it was just a coincidence, right? Because we don't have a large amount of data, and but a strong link has not really been established, right? But the typical appearance here is that you're going to have sort of nodular appearing, mostly subcortical lesions that you're going to have clustered in one area that may extend to the cortex, and they typically do not enhance. So that's a very typical appearance of an MVNT. And there is also a very similar appearing entity in the posterior fossa that you might encounter. So the next major group of tumors is the ependymomas, right? And we used to think about ependymomas as one large entity that can occur in the brain, in the spine, in the posterior fossa. But now, with all the molecular and genetic advances, it has been found that these are essentially different molecular entities, right? Depending on where they occur, right? You have ependymomas that are going to be supratentorial, right? And you don't need to remember this, but there's ones that are RELA fusion positive, there are RELA fusion negative, but they have other types of fusion. These are tumors that only occur in the supratentorial region. There are other types of tumors with different mutations that only occur in the infratentorial region, posterior fossa A, posterior fossa B. Depending on the type of mutation, they're going to have different prognoses. And then you have your spinal tumors, the spinal ependymomas, right? Where you have your mostly in adults, those associated with neurofibromatosis type 2, right? Or NF2 related schwannomatosis, as it is now called, your myxopapillary ependymomas, right? So essentially they are different molecular entities. They will behave differently depending on the type of molecular alteration that they might have. Just understand that they are now treated differently rather than considering them to be part of the same entity. Now, the classic posterior fossa ependymoma that we know that we usually see in children and young adults is this tumor that you see here, where on the CT you see a large tumor that looks very heterogeneous. You can appreciate some areas of calcification than here. This is T1 non-contrast. This is post-contrast. Here you can see that the tumor goes down through the foramen magnum and through the foramina, the fourth ventricle. These are tumors that are very soft, right? So they tend to go into into the path of least resistance, right? Some what people talk about or refer to as like a toothpaste type of spread, right? So, but the presence of calcifications, cystic changes, and kind of heterogeneous appearance. Sometimes they may be hemorrhagic. That's very characteristic for an ependymoma. Here's one that is supratentorial. Remember that this is a distinct entity, as we mentioned, right? Different molecular alterations. Now, this one is one that looks more aggressive, right? It's larger, a lot of cystic change, some heterogeneous enhancement. There is some areas of increased perfusion, so calcium, cyst formation, hemorrhage, enhancement may be heterogeneous, and restricted diffusion might be variable, right? And there's another type of ependymal tumor, which is the subependymoma. Now, these are tumors that grow slowly. They are a grade one, and the issue with them is that they are difficult to identify sometimes because, as you can see here on the T1, they tend to have a very similar signal intensity as the parenchyma. Right here, you can see that it's hard to see, right? Because most of them don't enhance, right? And the way to detect it here is that you don't see the lower tip of the fourth ventricle, right? It's just sort of blunted. So you have to suspect that there's something here. Now, they're a little bit easier to see on the flare, right? On the flare, they tend to be hyper intense, right? And again, most of them do not enhance, but some of them may enhance, right? As you can see here, location is pretty typical. This is the most common location. The second most common location is in the lateral ventricles, where you might find them as well. Now, how about this tumor? Here you see a tumor in the center of the corpus callosum. Now, the main features here is that the tumor is very homogeneous. It's solid looking. There's no significant hemorrhage, except for maybe a couple of petechial microhemorrhages. It's dark on T2, and there is prominent restricted diffusion. This is very characteristic of a lymphoma, right? It's just a very characteristic presentation. The other way that lymphoma presents is like in this case, where you can have tumor that kind of spreads around the ventricles, right? Infiltrates and spreads around the ventricles. The fornices here are involved as well. So this is very characteristic of lymphoma. Restricted diffusion is important. The homogeneous appearance, if you have an immunocompetent patient, that's important as well. But just remember that in patients who have HIV, who are immunocompromised, lymphomas might present more necrotic, right? Like a ring appearance. But this is another tumor where restricted diffusion is important. Here's another one, germinoma, also associated with restricted diffusion, highly cellular tumor. You see here dark on the ADC enhancement. On the T2 sequence, you can see sometimes there might be like a few tiny microcystic changes, like in this case, but the presence of restricted diffusion, especially in children and young adults, that's important for the diagnosis, or at least considering that the patient might have a germinoma. And if you have a CT, right, this is CT non-contrast, then you will see that because of that same cellularity, these tumors will tend to look brighter, right? They tend to be dense. Now, let's talk a little bit about dynamic susceptibility contrast perfusion. So this is the signal changes when the contrast bolus is going through the tissue of interest. And if you measure from here to here, that's the time to peak, right? And you can get a map of the time to peak. If you have a baseline here and you measure here the negative enhancement integral, this represents the total amount of contrast that is transiting through the vascular system. And this is roughly proportional to the cerebral blood volume, right? And this CBV, or blood volume perfusion, is what we use usually for neuro-oncology. Is the most studied, the most robust and widely used parameter, is what we tend to refer to for evaluation of tumors of the central nervous system. So our CBV perfusion is derived from this negative enhancement integral. Here we have a case of RCBB perfusion here in a patient with Lifro-Mini syndrome. They have an increased risk of tumors This is a patient who developed a low-grade glioma. You can see here very slowly growing tumor. 10 years before, the only thing you had was this kind of non-specific small T2 flare hyperintense spot here. Over 10 years, you see how it grew, right? No enhancement, and you have your color-coded RCBV perfusion map that it looks cold, right? So there's no increased perfusion. So um, the RCBB perfusion is a marker of the tumor proliferation, right? And compare that to this other case that I showed you from a glioblastoma, right? There's a lot of increased perfusion in those areas where there's enhancement, right? So that's more consistent with a high-grade tumor associated with increased perfusion. And so perfusion might help us as well when we're trying to determine post-treatment changes versus recurrence, right? We know that patients who have been treated, one of the main issues is knowing if a change represents true progression versus treatment-related changes. This is one example of that, right? This is a patient who has already been operated. The patient had a glioblastoma. There is a resection cavity in the left frontal lobe, and this is a couple of months after surgery. You can see that there is a new enhancing nodule here. So, of course, your first concern is, this might be progression, right? But then you do a perfusion map. This is a blood volume perfusion. There's nothing there. There's no increased perfusion. This is the tumor before surgery. You can see here very infiltrative, a lot of edema. This is just after surgery, immediately after surgery. On the ADC map, you can see that there was an area of infarction, right? So this is a perioperative infarct. So what we are seeing here is enhancement of that perioperative infarct, right? So this is pseudoprogression, perioperative infarction. So this should not be confused with true progression. Right? That's a case of pseudoprogression. And, pseudoprogression we typically see now with the treatment of glioblastomas with the regular protocol when patients receive the temozolomide and chemoradiation during the first 3 months after chemoradiation, they are at an increased risk of developing pseudoprogression. Here we have a case where you start seeing after the resection, you start having a growing nodule that keeps growing, and then without a change in therapy, it starts getting smaller, right? So this is a case of pseudoprogression. It is relatively common in gliomas, 20 to 30% of them within those first 3 months after chemoradiation. And that's secondary to an increase in the permeability of the blood-brain barrier. So it is not true tumor progression, but it's just this inflammatory response where there's more contrast enhancement. So it's important to recognize that as a possibility so that so that we don't need to change the treatment unnecessarily. Now, this is the other end of the spectrum where you have a tumor here, where if you look at time point 1 and time point 2, you see that the tumor is increasing, right? Went from this to here, right? So we think that this is progressing, right? So the patient is put on bevacizumab, which is an anti-angiogenic therapy. And after you put the patient on bevacizumab, you see it goes from here to here. So if you look at the post-contrast images only, then you see, oh, well, the tumor is getting better. There's less enhancement. It looks a little bit smaller on the post-contrast sequences. But look at what happened on the T2 and the flare. It went from this to this, right? So the tumor actually looks much larger, more infiltrative, more solid. So just by looking at the T2 and the flare, this looks like progression. And on top of that, you do perfusion, and that's your RCBB perfusion. You can see how red it looks there, right? So that area has a lot of increased perfusion. This is a case of pseudo response, right? So the patient is progressing, right? But it also almost seems as if it's responding, right? But this is a fake response. This is a pseudo response that happens in patients who are placed on anti-angiogenic therapies. Now, where does spectroscopy fall? We do not do a lot of spectroscopy. We may do it on a needed case-by-case basis, but we do not do it much. But there are certain principles to remember. In spectroscopy, you know that choline is a marker of cellular turnover, right? And NAA, N-acetyl aspartate, is a marker of neuronal density, right? Creatine will be more or less stable. So what we do is you usually look for ratios, right? We usually do not quantify, right? But there is some places that do quantify. It is a little bit more complicated, but we look for ratios. How choline, NAA, and other metabolites uh, change in relation to each other. So here you have a case of a low-grade glioma. You see the voxel here, and you have very high choline with decreased N-acetyl aspartate, right? That means that there's a lot of cellular turnover. This is a typical profile of a tumor, right, of malignancy. And but if you look outside of the tumor, right, the voxel here is outside of the tumor, you have a normal profile, right? Choline is lower than NAA, right? So that's what you would expect with normal parenchyma. This is a low-grade tumor. But if you go and you look at a high-grade tumor or like a glioblastoma, in this case, this is a glioblastoma, your voxel is here. Yeah, you expect to see a lot of choline, right? Little N-acetyl aspartate. But in glioblastoma, because we know that there is malignancy, there are tumor cells outside of the areas of enhancement. Now you can see here this voxel that is outside of that area of enhancement. You still see that there is an abnormal spectrum, right? Choline is very high and acetyl aspartate is very low. So that is consistent with the behavior of glioblastoma that, it's not only the enhancement that we see, but we know that there is going to be malignant cells scattered throughout the brain, and that is why it is such a difficult tumor to treat. Because even if you take out the entire enhancing component, uh, almost always there's going to be cells that are left behind. Now, the other issue that we commonly encounter is radiation necrosis, right? After treatment of glioblastoma, treatment of metastases, right? This is a patient who had a metastatic lesion that was treated. You can see it here, some central enhancement. We do a perfusion, RCBV map. This is a monochrome map, grayscale map, where there is no increased perfusion. We do a spectroscopy. You might see large lactate and or lipid peaks. You see that other metabolites are suppressed. And the typical appearance that people talk about here is like a cut bell pepper, right? Where you have these central bright areas like here, and then the margins might look a little bit like wavy, right? Like in this case, another good example of wavy margins and central enhancing areas. This is very characteristic of radiation necrosis. Radiation necrosis, you might see it in different stages during treatment, during radiation. It's very rare to see it during the acute setting, during radiation. You may see it in the subacute setting within 3 months, but the radiation necrosis that we tend to see for the most part is in the late settings, months to years, when there's vascular damage and edema due to capillary transudation. That it can be from like 6 months to 1.5 years, which is the most common, but sometimes even two, three more, or even more years after the original radiation. So it's important to try to understand the extent of the field of radiation, and at least consider that. And you can use perfusion. You can try to use spectroscopy, a short interval follow-up. But that's one of the caveats of imaging is dealing with radiation necrosis. So we have reviewed a lot of different things today. Where we looked at different features of brain tumors. Some of them are distinctive. Some of them have imaging overlap. We talked about there being a lot of emphasis on molecular imaging. Now, I think that neuroradiology as a field is going to have to evolve and try to come up with better markers or more markers to try to correlate with molecular changes. We looked at some of those, like T2 flare mismatch sign. We looked at the utility of diffusion restriction, perfusion, MR spectroscopy, some utility of SWI, and some of the challenges in image interpretation of treated gliomas. We looked at cases of pseudoprogression and pseudo response as well. And this is our basic protocol that we saw. I think all of these sequences throughout our talk. These sequences are very helpful to us. We use them on an occasional, on a case-by-case basis if we need them, if we need high anatomic detail. You can use this QR code. You will see the parameters, slice thickness, and other things if you're interested in looking at our basic protocol. And with that, I will stop here, and I thank you all for your kind attention.
Thank you, Professor, for your comprehensive and insightful lecture. So, as I mentioned earlier, if you have any questions, please you can either type it in the in the chat box or in the Q&A box. So far, I do not. Okay, so we have a question. So I will read out the questions, Professor. Is it okay?
Yes, please.
Okay. So how to differentiate solitary metastasis from glioblastoma?
Sometimes it's difficult. If you have a characteristic tumor, like the one that I showed, like that, butterfly glioma that goes over the corpus callosum, that, you see SWI, you have bars and dots on SWI, like it's very characteristic, then we say this is a glioblastoma. Some of them really look like that. Others are more difficult. And sometimes we have to say, this is consistent with a primary high-grade tumor like a glioblastoma versus a metastatic disease. So sometimes you can tell, sometimes you cannot tell, um, especially because now there's glioblastomas that might look a little bit atypical. One thing that may help is if you have a tumor, let's say you have an enhancing lesion, but then you have an area that is not enhancing, right? Like you have a T2 expansile area adjacent to it. So yes, you see other features that are more like infiltrative glioma looking, plus the enhancement that that's going to be a glioblastoma or a high-grade glioma rather than a metastatic lesion. Yeah. So if it's typical, you can tell, but sometimes it is hard, and you have to offer both possibilities.
Okay, thank you, Professor. So we have three more questions. So the first, I will read out the question as per this, according to the timing. So there is a second question is, any reason for doing the T2 sequence post-contrast?
Yes, that's a good point, and thank you for bringing that up. The reason why we do it here, it's not for the sequence itself. The T2 sequence is not gonna really change much after contrast. So, in theory, there is an optimal timing to do the T1, and there is consensus recommendations for that. To do the T1 after contrast should be between 8 minutes to 10 minutes after you inject contrast, right? So the reason to do T2 after contrast is to push the T1 a little bit further.
Okay.
That's the reason, it's just to insert a little bit of space. Now, the key sequence, that one is different because that one does show contrast. So I think it's important to have contrast for the key sequence. But for the T2, is essentially to push it a little bit further out. The other thing that you can do is you might do the flare after contrast. Sometimes flare is affected by contrast. If you are looking for leptomeningeal metastases, it's very good for that, right? So you could do it after contrast as well. But it's more of a matter of timing, the T1 post-contrast.
Okay, so we have the third question is, does abscess always have a double rim on SWIs?
Not always. Not always. It might be a technique thing. Sometimes it just, maybe there's not a lot of phagocytizing macrophages, right? So the answer is no. But if you see a clear double rim, inner bright, outer dark, then that's essentially pathognomonic, right? So it's helpful if you see it well. If you don't see it, you don't always see it. So, it's not that helpful.
Okay. There's another question from Balraj. So his question is, how will you differentiate bone tumor, sphenoid wing tumor. So I'll repeat again. How will you differentiate a bone tumor, sphenoid wing tumor from hemangioperocytoma in cellular area with cavernous sinus orbit involved? Did you get the
How to
question?
how to
I
differentiate a
said,
solitary fibrous tumor from the sphenoid wing?
yes, I think sphenoid wing bone tumor from hemangioperocytoma in the cellular area. I think with cavernous sinus orbit involved. I'm not sure if I'm reading it correctly.
Uh,
Basically, it sounds like how to differentiate a sphenoid wing bone tumor from hemangioperocytoma in the cellular area, I guess.
um, well, I think you have to look at the epicenter of the lesion, right? First of all, solitary fibrous tumor, it's hard to distinguish from even meningioma, right? Like some of them might look like just meningiomas, right? But I think the epicenter of the lesion, is it like a bone lesion, extradural lesion, right? That's more likely to be a bone lesion, right? Rather than an intracranial dural based extraaxial lesion that is invading the skull base, the sphenoid wing. That could be a meningioma or a solitary fibrous tumor. I think it depends on how it's behaving, but essentially probably the epicenter, right? The problem with some of these lesions is when they get large enough, it's hard to know where they started, right? So there could be some confusion there, but uh, yeah, I think of solitary fibrous tumors more intracranial than primarily bone based.
Okay. Okay. I have a question from my side. So, what is the role of MRS in brain tumor imaging? So, does he have any role?
MR spectroscopy.
Yes, and I'm wondering how frequently MR spectroscopy is done in US for brain tumor. Yes.
I would say rarely. We do it rarely because also there's some overlap. For example, demyelination, you do spectroscopy, you might have increased choline, you might have decreased NAA, it might look like tumor, but it's demyelination. There's areas where there's overlap, right? So I think it's done rarely. That being said, there are some areas that do it more often, that do it well. They might have different techniques, with more detailed spectra. They might be able to do quantification. There are places who are doing, for example, 2-HG, hydroxyglutarate, which is a way to try to determine the status of IDH by doing spectroscopy. Um, so then you can follow the tumor and try to measure whether a new area of enhancement maybe has increased 2-HG, right? Then you might be more concerned that that's recurrent. So in general, I say we do it little, but I know that there are some places that do more of it, right? They're more specialized. They might be doing different things that work for them, but it's just not widely spread. So yeah, that's one thing. And if I might mention as well, like nuclear medicine, of course, as well. I mean, I do not do nuclear medicine, but um, PET, right? FDG PET has been used in the past, but now there's amino acid PETs, right? There's some of them that are being used successfully in Europe, right? To try to help with questions of progression and pseudoprogression. Here in the United States, because they are not yet FDA approved, they are really not being used a lot clinically. That might change in the future, right? But that might be one of the ways to try to help with telling true progression versus pseudo progression.
I think we'll maybe take a last question since we are out of time. So the last question will be, when do you do DTI in tumor imaging, diffusion intensive imaging in tumor imaging?
DTI sometimes is requested. We do it upon request by the surgeon. If we have a tumor that might be in an area where we think it might involve the corticospinal tracts, or if it is felt that it might affect surgery, we might do it, right? And some of them, they just need the data to be introduced into their navigation system so that they can take into account when operating the tumor. So it's on a case by case basis as well. But it's to try to determine um, essentially fibers might be infiltrated by the tumor or displaced by the tumor uh, to help with surgery.
Thank you, sir. So I think now we are out of time. So on behalf of everyone, I would like to extend a huge thank you to Professor Dr. Carlos Zamora for sharing your invaluable knowledge with us today. I'm pretty sure that every one of us, me included, we can go back and we can improve the quality of our reports. So thank you again, sir.
Thank you so much. It was my pleasure.
Thank you, Dr. Zamora and Dr. Sange. I'm going to take it from now, from here. So I would like to do 2 minutes of the housekeeping here. Can I share my screen?
Thank you, sir.
Let me share my screen. Dr. Zamora and Dr. Sange, if you want to leave, please do. Please do. This is just little things for an announcement. Let me
Thank you so
share
much.
it. Thank you. Thank you.
Bye.
Okay. So here is the points of contact. If you have any trouble with this broadcast, any IT issue or certification of attendance, please contact this email arep2025.it@gmail.com, and the IT team will take care of that. And for whatever the topics you want to listen to, and you would like to hear that topic next year, please email Dr. Wint at University of Illinois. Her email at tariwint@gmail.com. Anything about the membership issue here, please email Dr. Sange, who is our moderator today. Kinley
Excuse me.
Sange 1323@gmail.com. And everything else, you can email it to me. So my email is this Sterpen, STERPENN @wakehealth.edu. And our next session will be, let me try to can I, okay, go back. So our next session, this is our last of neuroradiology session. Next 3 will be cardiothoracic. We will start with the aortic emergency. Our speaker is Dr. Patel from University of Michigan. She is an expert of cardiothoracic imaging over 20 years. So she'll be giving a talk about the aorta. And our moderator is Dr. Bold from Mongolia. So please stay tuned. This will be on in the next on the next Sunday, 15th of March at the same time. Okay, I would like to close our webinar for today. And thank you everyone for joining us. And we hope to see you again next time. Have a good day.
Thank you.